Good morning, everybody, and welcome to TIRO Multidisciplinary Seminars. The topic this morning is certainly a very timely one and one that very anxious to hear. We are honored this morning to have two outstanding presenters. The first is Dr. Naifa Busaidy, is professor at the University of Texas MD Anderson Cancer Center. In addition to her clinical work in advanced thyroid cancer and director of the Thyroid Nodule Clinic, she is widely recognized for her clinical investigations in the management of advanced thyroid cancer. She is a PI and co-PI for NCI and industry trials, as well as a member of the NCCN Thyroid Cancer Guidelines Committee. She is also very active in her leadership roles at the ATA and ITUG. And our discussant this morning is Dr. Frank Worden, who is a clinical investigator at the University of Michigan. In addition to his work in advanced thyroid cancer, he's also a member of the multidisciplinary head and neck cancer and lung cancer teams. Dr. Worden's research includes organ preservation in both head and neck and endocrine cancer. He will be discussing Dr. Busaidy's presentation as soon as she finishes up. For full disclosure, both Dr. Busaidy and Dr. Worden are members of the TIRO Advisory Board. And so I want to thank you both. And as always, I want to encourage all of you who are listening to send in your questions. This is a really unique opportunity to gain a deeper insight into this morning's topic. And so with that, Dr. Busaidy, I'm going to let you go ahead and get started. As always, I want to thank both our presenters for carving out the time to present, and thank all of you who are listening to thank you for joining in this morning.
So good morning, everybody. That was such a kind introduction. Dr. Erkin's always very generous with his introductions. So this morning, I am going to discuss with you a randomized controlled trial that we did looking at single agent dabrafenib versus the combination of dabrafenib and trametinib. And I'm here on behalf of all our co-authors discussing this paper today. So as a way of background, there are FDA-approved therapy. At the time that this protocol was written, there were FDA-approved therapies, sorafenib and lenvatinib, for radioactive iodine refractory differentiated thyroid cancer. That's progressive, but those drugs had several adverse events. And there were many ongoing efforts in many cancers for personalized approaches to therapy. Knowing that BRAF mutation is the most common mutation that occurs, especially in papillary thyroid carcinoma, anywhere from 40 to 70%, and there were preclinical studies that show that BRAF inhibitors can reduce MAP kinase signaling and tumor growth. And in addition, there were retrospective and prospective studies that had shown efficacy of single-agent BRAF inhibitors in differentiated thyroid cancer. So putting all that together with the fact that the combination of dabrafenib and trametinib were approved in anaplastic thyroid cancer, melanoma, and non-small cell lung cancer at the time that the paper was written, and have shown that the combination of these drugs, dabrafenib and trametinib, are approved and have shown superiority over single-agent BRAF inhibitors, dabrafenib especially. So we decided to go ahead and design an investigator-initiated randomized phase 2 clinical trial, open label, of single-agent dabrafenib, which throughout the talk I'm going to call D, versus dabrafenib and trametinib in combination, called DT. So we'll call it single-agent versus dual therapy throughout the talk. Trametinib is a MEK inhibitor, and the dabrafenib is the BRAF inhibitor. The hypothesis behind this protocol was that the combination of dabrafenib and trametinib, or DT, in BRAF-mutated differentiated thyroid cancer will result in greater clinical efficacy than single-agent dabrafenib. And the idea was that if we can mitigate the MAP kinase pathway and mitigate potential mechanisms of resistance, that then patients should do better with that combination. So the methods that were used in this paper were that we had patients, adult patients, so anyone over the age of 18, and they had to have BRAF-mutated thyroid cancer, differentiated thyroid cancer. They could test for their BRAF locally. They had to have measurable disease and show resist progression within a 13-month period. They had to have radioactive iodine refractory disease defined as the typical 4 that we see defined. So 600 millicuries or more, a negative radioactive iodine scan with known metastatic or local disease, progression or a new lesion within 12 months of radioactive iodine, or FDG avidity in their lesions. So any one of those criteria could meet it. They were allowed to have up to 3 prior multikinase inhibitors, except for a BRAF or a MEK inhibitor exposure. And this was done across 5 academic centers in the United States: Ohio State, University of California, San Diego, Mass General Hospital, University of Chicago, and MD Anderson. The patients who were randomized to single agent dabrafenib were allowed to cross over to add trametinib, so the combination drugs at progression. And they were given single agent 150 milligrams every 12 hours, which is the FDA approved dose for those other cancers, as well as the combination was dabrafenib 150 milligrams every 12 hours with MEK inhibitor trametinib 2 milligrams. So again, the FDA approved dose for those other cancers at the time. So the endpoints in the trial, the primary endpoint was objective response rate by modified RECIST. And what do we mean? So typically objective response rate means complete response plus partial response only. And we added a third category called minor response. So if complete response, everything has to disappear. Partial response, you had to have more than 30% shrinkage in the sum of the diameters of the lesions. Minor response was between 20 and 29% sum of the target lesions in the first 6 cycles, or within the 6 cycles. So we sort of added that because in thyroid cancer, we felt that while we're not going to say complete response, partial response, and stable disease, is a clinical benefit, which many people think of. For the trial purposes, we would add minor response. So secondary endpoint was the duration of that objective response rate, progression-free survival, and overall survival, as well as safety and tolerability by common terminology criteria, adverse events version 4, and then we did pharmacokinetics or PKs in a subset of patients. We did do correlatives in a subset of patients. We did tumor mutational testing at baseline as well as progression, and I'll show you some of that data. The statistics for the trial were based on the primary endpoint of objective response rate. So we used the Sargent and Goldberg flexible screening design to evaluate treatment regimen and screen for more promising phase 3 studies. That's a lot of words, and what we basically meant was it's kind of a cool way to look at clinical efficacy of one drug versus another in a randomized trial. So it doesn't exactly tell you for sure this is the right answer, but it looks for superiority of one over another. So for this trial, we assumed a true difference in the overall response rate was 0.2 or a 20% difference. So for example, 15% versus 35%, that we'd have 90% power to identify the more efficacious regimen if we had 26 patients randomized in each arm, or a total of 52 patients. And if the actual observed overall response rate differed in each arm by 10% or more, this would go forward. And then we use chi-square statistics, Kaplan-Meier, and summary statistics for the rest, and I'll share that with you. So this is our consort diagram. And basically, we initially started with 69 patients that were eligible. 16 patients didn't quite meet the inclusion criteria, or one of them declined to participate. So we ended up randomizing 53 patients across the 5 sites. And Arm A was considered the single agent dabrafenib. There were 26 patients. And Arm B was the combination of dabrafenib and trametinib. There were 27 patients. And this was intention to treat. And so these patients then were followed up. 23 patients ended up discontinuing their intervention, either due to disease progression, adverse events, death, or patient withdrawal. And in Arm B, or the combination therapy, 26 of them ended up discontinuing intervention, either from disease progression, adverse events, intercurrent illness, or the patient withdrew. So we ended up analyzing, because it's an intention to treat, all 26 patients in Arm A and 26 patients in Arm B. So with those 53 patients, when we went in to write this study, three patients were on 3 of the patients on the single arm and 2 of the patients on the combination arm ended up going off study or died prior to their first restaging, which is why you'll see the numbers change when we show you the objective response rates. We end up with 48 instead of 53. And the baseline characteristics, I want to go over the table from the paper. So here you'll see the 2 columns of single agent dabrafenib versus the combination. And the baseline characteristics were very similar, and typical as many of these trials, the higher percentage of patients were male, even though in thyroid cancer, most of the patients are female, but you'll see all these advanced trials are either 50-50 or have a slight majority of males because they tend to have more advanced disease. Their ECOG performance status was fairly well balanced. Most of the patients, as goes with the cancer, especially BRAF mutant, were papillary thyroid cancer, but we did have Hürthle cell, poorly differentiated, and a follicular, and we're going to talk about some of those later. So the vast majority of patients had V600E, which you would expect, but there was one patient that had a K601E, which we'll talk about as well when we look at the results. And then the vast majority of patients had lung metastases, but again, these were well balanced between the two drugs. And again, this is something you would expect with advanced thyroid cancer. And remember, we allowed up to 3 prior kinase inhibitors, and you can see that 11 patients, well balanced between the two studies, had prior kinase inhibitors. So the vast majority of these patients were treatment naive. So the median duration of, if here throughout the talk, if I show blue, it's single agent dabrafenib. If I show red, it's dual agent, a combination therapy of the two drugs. So the median duration of follow-up was about 22 and 25 months in the two groups. And the median duration of treatment, meaning they were on treatment for about almost 1.5 years. So we had good follow-up, and they were on treatment for quite some time. 3 patients at the time of this paper were still on study. So when we look at the efficacy data, the primary endpoint, remember, was objective response rate. So we added partial response, complete response, and minor response. We did not have any complete responses. So if we added the partial minor response in the single agent dabrafenib, we had a 42% objective response rate, and in the combination it was 48%. And these numbers you can see here from the p-value were not statistically significant. Okay, so we were not able to prove from this trial that the combination was better than single agent on this drug. On this trial. So if you just broke down partial response and you wanted to see, I don't want to count the minor responses, there was 35% in the single agent and 30% in the combination of therapies. Still no difference seen. And if you broke it down and looked at those who had stable disease, because remember, all these patients had to have progressive disease to get on. So many of us feel that stable disease even is a win. But again, it was 38% in the single agent, 44% in the combination of therapy. Okay, so it's slightly higher in the combination, but these are not statistically significant. So it's just food for thought. So what about some of the other things that we've seen? So BRAF K601 is not common, but it does exist, and it can exist in follicular variant of papillary or follicular thyroid cancer. This patient was randomized to single agent dabrafenib and had progressive disease as their best response. In general, just so you know, if we weren't randomizing patients, if we were doing this on standard of care, we would put that patient on combination as they would in melanoma. Follicular thyroid cancer patient was on dabrafenib single agent, and he died due to progression. Now, Hürthle cell carcinoma is not something you commonly see with BRAF mutations. There have been 1 or 2 papers that have said these Hürthle cell patients have a BRAF. I always wondered if they, or oncocytic now they're called today. I always wondered if there was, it was misdiagnosed, but we looked back at this patient and they had a subclonal mutant BRAF V600E. This patient had stable disease for 5.7 months. And the poorly differentiated thyroid cancer patient was on randomized to combination therapy and had a partial response for 12 months, which is interesting, right? And we can talk about that in the Q&A. So if we come back to this table 2, and we look at duration of response, so the patients who had a minor response and partial response had 18 months on single agent dabrafenib, 17 months on the combination. This was not statistically significant, but did suggest that they had that response that lasted. So they typically will get the response within the first 6 months, and then it lasts for a good 1.5 years. So progression-free survival was not the primary endpoint like it is in many other studies, remember. We looked at this as a secondary endpoint. And shown here in blue is the single agent dabrafenib. In red is the combination of dabrafenib and trametinib. And it was 10.7 months in the single agent and 15.1 months in the dual agent. That is, although it looks longer for combination therapy, it's not statistically significant. This progression-free survival, there was a median follow-up of 23 months, so almost 2 years, and 36 patients had progressed, so we had or died. So we had enough events in each arm almost equal to do this. The 1-year progression-free survival, I will point out, for single-agent dabrafenib is 50%, and combination is 73%. The p-value is 0.08, so again, doesn't reach statistical significance, but it was a little bit of food for thought for us. And if you look at overall survival, again, the blue is single agent, red is dual agent. It was 37.9 months in single agent and 47.5 months in combination therapy, with the range shown here on the right-hand side. Again, this was not statistically significant, and we had equal numbers die in each arm to when we did this Kaplan-Meier curve. The objective response rate, this is the modified. I wanted to show you what the waterfall plot looked like, because so if you take that each of these bars are a patient, the blue bars are the patient that were randomized to single agent dabrafenib, and the red bars are dual combination therapy. This black line here at the bottom is the partial response rate, so the negative 30%, and this 20% is the minor response, what we defined as minor response. So anybody that had a bar that went below this had a partial response. Anybody that had a bar below the green line, the negative 20%, but not quite at the 30, was considered a minor response. So anything below this green is what we called an objective response rate, okay? And it was 11 patients in the single agent and 13 in DT, so the 42 versus 48% that I showed you prior. And that patient with the K601E had progressed through and is here on the left-hand side. So now I want to shift gears a little bit to the crossover. So there were 14 patients out of these 26 that were randomized to single agent that ended up getting combination therapy, or they crossed over to the other arm, okay? And what we show here is that if you look at the objective response of the partial and minor, 29% of them, after they crossed over, had a objective response, right? Because the thinking was, oh, if they progressed on single agent, are they really going to, shrink again after combination? And I would argue there actually may be a role, because there were patients here that did shrink. And 57% of them had stable disease. Remember, they had to progress with a new lesion or progression of lesions to get crossed over. So if you put that together, 86% of patients that crossed over, 12 out of the 14, had either a partial response, minor response, or stable disease, suggesting that if patients take single agent BRAF inhibitor, adding a MEK inhibitor later can add some efficacy. If you look at the progression-free survival after they crossed over, they had got an additional 7.5 months. And you can see the range was 2.8 months to 38.5 months. So some people got a lot more time out of the crossover. The overall survival was not different between, if you looked now, doing a bit of a different comparison, right? The patients who crossed over versus the patient who got the combination, it was 36 months versus 47.5. They were not different. So now what about the side effects? Almost everybody has some sort of a side effect on these drugs. But the grade 3 events, which is how it's looked at in general in these oncologic trials, were about 58% in single agent dabrafenib and 48% in the combination. I will say the adverse events were not very different from what we see in the other trials, but I will show you the serious adverse events was a little bit of food for thought. So the good thing is there was no grade 4 or 5 adverse events on this trial, and we can talk about some of the things that we're seeing at the Q&A. And so if you look at the single agent dabrafenib, to summarize that long trial, is that that long table, there were more skin-related adverse events and hyperglycemia in single agent, which you would expect, right? I tell my patients on single agent, 90% of the time, you're going to have some sort of a skin-related if you're on single agent dabrafenib. And if you do the combination, those skin-related AEs goes down, but you have more fatigue, chills, and liver abnormalities. Now, when it came to serious adverse events, that's the top part at the top. It's something that we couldn't fully explain, and we can discuss. The single agent had less serious adverse events than the combination of dabrafenib and trametinib, even though they're grade 3s and others were pretty similar. And then if we looked at discontinuation of drugs due to adverse event, the numbers were about the same, about 19% in single agent and 22% in the combination of dabrafenib and trametinib. And if we had to dose reduce, again, the single agent actually here had fewer dose reductions than the combination of dabrafenib and trametinib. 15 patients managed to get into the subset that had pharmacokinetics done, 7 on single agent and 8 on the combination therapy. They had similar areas under the curve for dabrafenib alone, trametinib alone, and the combination of dabrafenib trametinib, as you see with other PK studies that were done in these trials. So nothing outstanding or different here in thyroid cancer patients. And then the correlatives that were done, there was 33 patients that molecular profiling was done in. They had on average about 4 mutated genes per patient. The range was about 1 to 9, but this 4 mutated genes include BRAF. TERT, as you would expect, was the most common co-mutation, occurring in 79% of patients. And then 3 patients had other co-mutations: CRLF2, NUP93, SDHA, and STAG2. These have all been described if you go back and look at the papillary thyroid cancer patients. And then at progression, we had 7 patients where we managed to have matching tissue. 4 had molecular stability despite progression out of the 7. And 2 of the patients gained 5 additional mutations and 2 additional mutations. And 1 patient who was on single agent dabrafenib had a clonal shift and a loss of a subclonal POLE mutation and a gain of MRE11A splice site variant. 1 patient on the combination of DT acquired mutations of KRAS and CDKN2C, which has been described in progression of these tumors. But it was interesting that 4 out of the 7 had molecular stability. There was no correlation with response. We couldn't do this because we only had matching tissue on 7 patients, right? The N was too small. 1 patient did develop an activating RAC1 mutation. This has been published elsewhere, and polyploidy of chromosome 7 with overexpression of RAC1 and other genes. So in summary, this is the first randomized trial of dabrafenib versus dabrafenib and trametinib in differentiated thyroid cancer. And what the conclusion ended up being different from our hypothesis. So dabrafenib is effective therapy and similar to what has been shown in other BRAF inhibitor trials, but the combination therapy with MEK inhibitor was not superior. And we can talk about why that may be and why some people feel that it may still be superior. We did see a lower response rate compared to melanoma and compared to anaplastic thyroid cancer. And there's lots of theories for this, but our main theory is that, oncogene addiction and with papillary thyroid cancer, which is the vast majority of these, and that these tumors may not mount alternative mechanisms to support MEK activation, right? To suggest that you actually need that inhibitor. And, because otherwise it's difficult to explain why melanomas and ATCs sort of melt away, and ATCs don't even do it as well as PTCs, but you do see it with melanoma. And so some limitations of this trial and some food for thought. So, it might be that combination therapy of dabrafenib and trametinib is superior in a subset of patients, and this trial wasn't designed to sort of pick out who those patients are. It wasn't powered for a difference in progression-free survival, right? It was powered for a difference in objective response rate. And maybe if we had done that to progression-free survival, we may have seen a difference. And we also didn't look at what was the rate of progression, right? So to get on the trial, you have to have progression over 13 months, but some of these patients progressed over 3 months, some of them progressed over, 12 months. And are those, we know clinically when we see those patients, they're not necessarily the same. And then one thing that is food for thought, that is utility of BRAF inhibition versus, getting, anti-tumor effect from the anti-angiogenics, and which drug do we use first in BRAF mutated patients should be discussed carefully with each patient, right? And look at their comorbidities, and do they have blood vessel involvement or risk for fistula or severe hypertension or MI or, things that you would worry about with an anti-angiogenic. So just some things to think about. So with that, I'd like to acknowledge that thanks to our patients who participated in the trial and are always willing to teach us something and benefit not only themselves, but others, and all the colleagues, both at MD Anderson and outside, and as well as in the multidisciplinary, because it takes a whole village to see these patients, right? And I'm just up here summarizing our paper. And I really want to put a big shout out and thanks to Manisha Shah, who really got us together years before this trial opened and sat down and forced us to think about this idea. And all the co-investigators at Ohio State, Mass General, UCSD, University of Chicago, and at MD Anderson. This was funded by National Comprehensive Cancer Network, and we did get drug from who originally was GlaxoSmithKline, and then Novartis took it over later. And we had been talking with GlaxoSmithKline at the time about going forward with a phase 3 before we had these results and going for registration. Turns out when Novartis took over, there wasn't an interest, but lucky for us, we ended up getting tumor agnostic approval for Dabrafenib Trametinib in combination for any tumor that has a BRAF mutation. So if you fail first-line therapy, right? So we're lucky in that we have these drugs available, and it depends on how you define first-line therapy. I'd be interested in Dr. Worden's thoughts on that, because some people say first-line therapy is after failure of sorafenib and lenvatinib, right? FDA-approved MKIs. I say first-line therapy is surgery and radioactive iodine, so therefore they can have their BRAF inhibitor. So I look forward to the discussion, and I want to thank TIRO so much for inviting me to speak, and I had a lot of fun doing this, and I'm looking forward to the Q&A without bashing.
That was great, Naifa. And you're one of my biggest fans, so I would never bash you. Let's see if you bring my slides up. Can everybody see my slides here?
Yes.
Yep.
Okay. So, yeah, go ahead. You said something?
No, it's good.
Good. All right. So I'm going to add a little discussion to this. Again, it's really more of a healthy discussion for us to think about things as we now have a lot of agents to play with in the sandbox of thyroid cancer, where years ago when I finished my fellowship in 2000, I look at people and say, we're just going to watch your disease. So this is really, really excellent. And I'm just really very happy that we have this opportunity to discuss such great new therapies. So these are my disclosures. I will also disclose that I am not part of the sign scandal at the University of Michigan, nor do I know Jim Harbaugh personally. So here is the money slide. So now anybody really with RAI, refractory disease, NGS is mandatory. And at the beginning, when people come in for surgeries, perhaps, we could check for these driver mutations, but we necessarily don't know how to alter therapy by them. But when people become refractory to iodine, it's important. And so today here, we're talking about the BRAF mutant. And as Naifa, alluded to, this is probably the most common of the driver mutations, in particular in papillary thyroid cancers. And you see these other co-promoter mutations. And in combination with BRAF or RAS or RET, perhaps NTRK, you can see a more aggressive form of these cancers in which the symporter becomes inactivated. And so therefore the patients developed ultimately radioactive iodine insensitivity. So looking in particular BRAF, so Marcia Brose kind of beat us all to the punch with this first study in vemurafenib as a single agent. So this was in patients who were MKI treatment naive, as well as those who actually had previous treatment. So you can see here progression-free survivals from 18 months in the naive patients to about 9 months in those patients who had previously been treated. So then Naifa did an excellent job presenting her study. And so this is just the highlight of those things, are the data that she presented here. Again, what I take from this is, yes, it was not powered for progression-free survival. And so that, comes into question, because as we look at these large international studies, they were done as such. But nonetheless, I think that there is, perhaps this trend toward maybe improved progression-free survival or survival, perhaps with the combination of both drugs. And we'll talk a little bit more about how perhaps other agents could be used. And then response rates, as she talked about the overall response rates of, 35% and 30%. What I think is important here, the study looked at this modified response rate, which I do think is important, and we can talk about that. But it's also important to point out the RECIST response rates, because when those of us who are very familiar with thyroid cancer, we understand this data a lot better than people perhaps in the community who are trying to figure out what to do with this disease. And so when people come in and they read papers, it's important to note that the other studies that have done in thyroid cancer did use RECIST directed response rates. And so to know what those response rates are in this study would be very important. So, some thoughts about this. It is a randomized multicenter study. So there were several sites that were involved, which is very good. The median time to follow up is almost 2 years, which is good. And then crossover was permitted, as Naifa, talked about, and even having a benefit in patients who were crossed over from D to D plus T, which I think is an advantage. And it offers us some information to know that we could get some more mileage for our patients instead of just abandoning a combination or single agent BRAF inhibitor and moving on to something else. Side effects. So I think what's important about this, and Naifa talked about this quite well, is that we understand the side effect profiles of any of these agents. So I think oftentimes people think, oh, single agent drugs for RET or NTRK that are these driver mutations, and you look at the kinomes and really there's just one target you're going after, come with lesser side effects. But even with those drugs, selpercatinib and larotrectinib, entrectinib, you can see some pretty significant side effects where patients have to permanently discontinue. And the same thing here is that just because we're going after a main target or perhaps a main target and a downstream target doesn't mean that we can't, have side effects that can lead to issues. The good things she pointed out are the lack of grade 4 and grade 5 events. And I think over time, especially those of us who have treated melanoma patients and lung cancer patients and other cancers who have these BRAF mutations, we're becoming more familiar on how to use these drugs and manage side effects. But nonetheless, as she alluded to, the hyperglycemia issues with D alone and the skin disorders and the fevers and chills when the combination was given. And then the important point here, she kind of alluded to this, but I'd like to bring this up, that there was not side effects associated with bleeding, proteinuria, DVT, hypertension. Those we see in the multi-kinase inhibitors, and that is really important. So as we think about this hierarchy about, perhaps how we should be approaching patients, this side effect profile with these multi-kinase inhibitors is very important. So perhaps the agents that she's talking about in today's presentation would be a major advantage for some patients, because there are people who do come in and have inabilities to tolerate drugs because their hypertension is not controlled, or they're at high risk for bleeding because the tumor is involved or invading perhaps the carotid artery or other vascular structures. The study was small. It is with 53 patients. And again, as she alluded to, it was not powered to reflect the difference in progression-free survival. And so we know from some of these large randomized studies for the multi-kinase inhibitors, they did look at progression-free survival. So again, comparisons can be, a little different. We have no confirmatory data yet. And then the agnostic FDA approval for D plus T from the NCI match actually did not include the thyroid cancer data. So it has this indication and we can use it for these drugs. They did look at thyroid cancer patients, but when they put the data together to actually get this approval, they actually did not include the thyroid cancer data. And toxicity, again, differs for TKI therapy, but again, is not trivial for any of these drugs. So when we kind of look at this all together, this is a list when I was saying at the beginning that, wow, this is great. Here we are in 2023, we have these active drugs in thyroid cancers compared to way back in the 90s and the early 2000s where we didn't really have anything. And so what's important here is to look at response rates as well as, progression-free survival and kind of putting this together and what makes sense for our patients. So I will be the first to say that sometimes, and Naifa nicely alluded to this, that response rates can be overrated. So certainly patients who come in with bulky disease that is causing pain, or they're having a large amount or high degree of lung disease that's leading to difficulties in breathing or performing activities of daily living, response with a multi-kinase inhibitor may be important, because we really want to shrink down, the tumor to help patients to go back and enjoy what they were enjoying before they were so debilitated. Even in the SELECT study, we did a retrospective review, and in older patients, there actually was a survival benefit over placebo with lenvatinib. And the important point there was probably that these people had so many comorbidities that when they were symptomatic from their thyroid disease and we reduced that, they were able to cope better with their comorbid states, which probably led to an overall survival benefit. But nonetheless, I think it's important for us to think about that, but also not rest our hats completely on overall response rates, meaning that even in this study, the response rates were lesser. But as she alluded to, stability of disease can be a very good thing in our patients, especially those who are progressing enough to go on a study, but perhaps aren't exhibiting the great amount of symptoms that other patients perhaps are experiencing. So kind of putting this together, she is correct. I am also an NCCN thyroid cancer member on the panel I joined this year. So it does say in patients who have had previous treatment, and one would argue that RAI surgery, or some targeted therapy such as radiation or ablation could be considered pre-treatment before one would get a BRAF inhibitor or combination. But if you think about it, based on the data that's published that we've kind of looked at here, looking at these response rates, looking at these large studies that we're looking at progression-free survival, one could put this as saying that if you truly have a TRK fusion or a RET fusion, that these targeted therapies should be considered. Pralsetinib is actually not on the market anymore for RET. But here we see patients we're going after one target. We can see some very impressive response rates of close to 70 or 80% with both of these two categories of drugs. Toxicities that are actually manageable for most patients, and then duration of response and even median progression-free survivals that haven't even been reached. So I think a lot of us would say if we find these fusions, that would be first-line therapy. And then if we don't have those fusions present, our true first-line therapy may be, multi-kinase inhibitor, lenvatinib, probably over sorafenib, for the fact that the response rates are much higher. And progression-free survival was much more improved over placebo as compared to sorafenib. But nonetheless, taking into consideration of, the toxicity profile that may exist. We didn't really talk about this today as much, but cabozantinib now is approved as a second-line therapy. So cabozantinib was, and the COSMIC study showed benefit over placebo in patients who were progressing. And when these people start progressing, they truly, can take on a more aggressive form, as perhaps they're transforming to a more, poorly differentiated form. And we can see that the placebo curves there dropped off more quickly than we would see in frontline therapy. So nonetheless, it could be that these multi-kinase inhibitors first, followed by another multi-kinase inhibitor, and then saving BRAF for patients who aren't able to get these kinase inhibitors. With that said, I would come back to say that people who necessarily don't have large progression of disease or could benefit, or if we think they're perhaps transforming into more poorly differentiated or anaplastic forms. So we do know that in papillary thyroid cancer, up to about 50% of these patients can actually transform to a more aggressive or anaplastic form. And we do know, as Naifa alluded to, that the immunogenicity or the microenvironment of those tumors are different. And we don't show data here today, but we know from a basket study that led to FDA approval that was done at MD Anderson that D plus T is beneficial in anaplastic thyroid cancer. So it may be that, again, looking at our patients individually, that may be a role to start with these agents up front. And then obviously pembrolizumab in patients who have high mutational burdens. Interestingly, in ITOG, we're actually submitting a paper and it presented an abstract showing that perhaps a TKI up front and then progression, we can get some more benefit from progression-free survival if we add in a checkpoint inhibitor. So I think personally there is room for a clinical trial, D plus T, versus lenvatinib. Again, looking at progression-free survival to kind of answer that question, kind of more head-to-head. Interestingly, there were some patients who were previously treated, on this study, so there could be room for us to look. So that would again help us to establish a hierarchy for, these patients. And perhaps, as she said, there are a subset of patients who may be more beneficial to start with, D plus T. Currently on ECOG, there is underway a cabozantinib versus D plus T in second line therapy. So if maybe a first line trial and then a second line trial would help us to establish better who might be, the right patients, for these drugs. And then BRAF inhibition. I know nicely, Naifa, you mentioned this in your paper, and I think it's an important point, to talk about, the whole development of RAS mutants, and then in those D plus T patients, sometimes we'll actually add in an MKI. But we know that when you down-regulate BRAF, you get this upregulation of, HER3. So it's reactivation of this mitogen active protein kinase signaling by BRAF and MEK. And so here you can nicely see, again, the activation. And then when you're inhibiting BRAF and MEK, you can see this up elevation of HER3. So I have a patient here, actually, that, interestingly enough, came in and had a papillary thyroid cancer, who is BRAF mutant, and initially had some RAI therapy, progressed relatively quickly. The patient was started on lenvatinib, and then actually progressed quickly through that, went on cabozantinib. And then this gentleman shows up on the right in December of 2020, and you can see the pleural effusions, the thickening of the septa here, suggesting massive lymphangitic spread. If you look at his neck, he had disease that was protruding in the right side of his neck that was painful. And so I chose to treat this gentleman actually with afatinib in combination with dabrafenib. And I did so because I think I have experience with afatinib, perhaps in some lung cancer. We have some data in head and neck cancer. I think maybe the toxicity profile is slightly better than that with, the MEK inhibitors. So I chose to do so. And then look at the left side here. This is July of 2023. The gentleman's neck disease completely went away. His lymphangitic spread resolved nicely. This guy was a former firefighter. He actually went back to work. He used to play golf and came in. He was losing so much weight. If I had a physical picture of his face compared now, you would see a drastic difference, how this benefit here. So perhaps maybe we need to look at combinations that involve, other agents such as this, broad inhibition of HER3 to perhaps maybe add even better benefit for this particular target. So with that, I will close, and I think we have about 15 minutes for questions and answers.
Terrific, and thank you, Frank, for an excellent discussion. Naifa, do you want, we're going to leave that picture up because that says it all here. Naifa, do you want to comment at all on Frank's commentary here?
Yeah, that was very nice, Frank. I always agree with you, though. But I have a question. Were you Ernie or Bert? Because, I don't see Bert here. I was Bert. So I'm just questioning what's going on here.
What's going on here? So Mark asked this too. So a few years back, I was fortunate enough to have had a patient who was very grateful. She passed away, and she and her family gave me an endowed professorship for thyroid cancer. And when I got to know this lady, and thyroid cancer patients, you get to know them over a period of time. We both have this love and fondness for Jim Henson. And I think, we used to kind of say this back and forth, but one of his famous quotes is kind of to the effect of, my goal in life wasn't to do something, to make my, self famous, but for making a difference in the world just for having been here. And, we kind of shared that. And I know, and she talked about in her life how, she made a difference for her kids who now are grown up and successful. And I think what I'd like to convey about that is to us as providers of, here, thyroid cancer patients, but, even in oncology altogether, that, we are making a difference in the world of these people. And, you know, just like we've been talking about today, the massive changes and the work that's been done, and I credit your institution, you know, completely for being at the forefront of the champions of this, Naifa, that, you know, our goal is to make a difference in the world for just, you know, being here for the lives of our patients. So when I gave this talk for my endowed professorship, I included this slide and that quote from Jim Henson. So this is always to remind me that, you know, even though when the chips are down and medicine's becoming more challenging with more burnout, and, you know, as well as I do, the things, the bureaucracy that we're facing, that, you know, I think about the difference that we can make in the lives of our patients individually, and how important that is. So that's the story.
Oh,
Yeah. Frank, we should have ended right there here, but that was the closing line. But thank you for sharing that.
Sure.
Naifa, I have a couple of quick questions. Some of these are going to come from a surgeon's perspective here. But let me ask you, one of the differences between the D plus the doublet therapy group was related to radiotherapy. And is the assumption here that the target lesions were not in the radiation field?
yeah. So you're right, we had patients in both arms, maybe a little more in, although it wasn't statistically significant, in the single agent who had been exposed to radiation. But the measurable lesions that were used for progression to get on trial were not in the radiation field.
Okay.
So that is correct, what you're stating.
Great. Okay.
Yeah.
So, and again, this is, I'm really putting on my surgeon's hat here, but in the crossover group, there was, is it unfair to add that progression-free? I know was not the endpoint, but is it unfair to add that significant improvement in progression-free survival when you added doublet therapy to the doublet group, and say maybe these numbers are approaching significance?
Yeah, so you're saying when the patients were randomized to single agent. Oh, I see. If we add the 14 crossover to the 27 that had combination therapy, is that what you're saying?
Yeah,
and
exactly.
Yeah. So it would be cheating, but it's very interesting food for thought, right? I mean, there are ways to look at that and say, hey, because I think what you're alluding to and what Frank had said was that maybe, you know, if we had a bigger study, because we were talking about this, two things throughout the study, you know, and as we were playing this out, and then even worse, when we were writing the paper, we're all sitting here arguing that, you know, probably our N was too small. And, you know, we used objective response rate so that we could do an affordable trial. And we thought that it was obviously an important endpoint, but it may have, you know, hurt us. Like, we don't want to come to the wrong conclusion. It's not that we think that single agent doesn't work. It clearly works. But maybe we could have shown the superiority if we had used progression-free survival. And so one way to do that, you're saying, is to combine those patients and you get a higher number. But unfortunately, we wouldn't. No, I don't think we'd be able to do that with a straight face. You know what I mean? Like in all honesty. But it is an interesting, you know, point. And I do think that, you know, when you see some of this data, and I think Frank showed really nicely in the BROS data with the BRAF inhibitor, that progression-free survival did look longer. Now, I don't remember how strict she was about progression in that trial. Frank can remind us. But it is food for thought in terms of maybe this trial was just too small, so we couldn't show the difference, but the proof of concept at least is there. And, you know, one thing that Frank was talking about is that while the data that went to FDA for the NCI match to get the approval didn't include the thyroid cancer, you know, they were trying to take their most robust data, right? Everybody has a trick up their sleeve to go present the data to the FDA and let's just get the drugs approved. We were just happy that we got the blanket approval, right? So that we're always fighting insurance, and, like, you know, Frank was talking about, medicine's getting more challenging and fighting insurance and doing all these things. Now we're like, okay, well, we have this, but now what's happening is, even if we want to prescribe just the single agent, okay, if you write a prescription for the single agent BRAF inhibitor, oftentimes the insurance write back and said denied, and you're like, why is it denied? Because it's approved, right? And they'll say, unless you prescribe this in combination. And you're like, oh, darn, because the approval is the combination, right? So then you end up writing both prescriptions, so it goes to insurance, but you only physically prescribe the one drug, right? So we're all finding these tricks to do these things, and it's sad. So I just wanted to comment on something Frank had talked about, which is in response to what you're asking.
And I want to comment actually back to the radiation piece too. This is important because oftentimes when you radiate people, and we do because they have growing disease in the neck or whatever, and then you challenge them with these MKIs, fistulas can be a big issue. I don't see that as much, and maybe Naifa, you can comment, with the D plus T combination or the D. So I think that's important too, because someone who's heavily radiated in multiple spots, I do worry about that, and so I think that's another potential advantage, to offer these drugs, up front, to people.
Yeah, and sorry, Mark, if you had another question, I just want to add to, I 100% agree, right, with what Frank's saying, is that, we have to individualize and personalize this therapy, not just to the mutation, but the patient's comorbidities and where their tumor is. And so when this paper, when it talks about radiation in those two groups, that radiation could have been to bone, could have been to lung, could have been, anywhere. So just so we know, so those numbers are quite high, but these patients, like Frank was talking about, a lot of these patients are around a long time before they actually need their MKI, right? You get to know them, for 15 years, and then they progress or whatever, and then they need. And so along the way, you might have done a localized therapy, radiation to their bone, or radiation to this spot, or SBRT to the lung, to the mediastinum. So, so that was why there was radiation, quite a bit of radiation in the trial, and some of them got it to the neck as well. And so when we think about nowadays, from the beginning, when we're thinking about this patient has aggressive disease in the neck and we're going to do surgery, and the surgeon, the radiation oncologist, the medical oncologist, the endocrinologist, we're all together talking and thinking, okay, this patient is probably going to need lenvatinib down the road. So do we really want to radiate the neck? Because like Frank was talking about, this is a patient who's at risk for fistula. So if this patient has a BRAF inhibitor and we really need to give radiation, a BRAF mutation, and we really think we need radiation, well, maybe that's the drug we're going to go for, right? And sort of individualizing it that way from patient characteristics, tumor characteristics, comorbidities and patient preference, I think is important. And the other thing is thinking about the adverse events, like Frank was talking about in his talk, is that, when you think about somebody who gets a lot of skin cancers, right? That might be a patient, because we know that if you get 30% risk of skin cancers with BRAF inhibitors, when you add that MEK inhibitor, it goes down to less than 5%. And I'm not saying we could argue about the cost of the drug and community health and just to get rid of skin cancers, because you can cut them out and things like that. But, it's something that we do think about with skin AEs. But if you think about lenvatinib AEs and the BRAF inhibitor AEs, there are patients who can lose a lot of weight, right? Even if their response rates are bigger or their longer progression-free survival, that cachexia is not to be underrated or under discussed. And I just think it's something really to think about. And we can always go from lenvatinib to add a BRAF inhibitor, switch to a BRAF inhibitor later, or the other way around, BRAF inhibitor and do lenvatinib, and they respond both ways.
It's true. There's actually data in second line with lenvatinib that was never published. It was presented at ASCO, but never published. And so I think that's actually an important point too, that we do have data, in multiple lines of therapy where they can show effectiveness. And so that's something we have to keep in mind. And she's right. Tailoring to the individual needs of the patient is important. It's one thing we stand up here and say, you should do this and this and this based on these studies and all that. Sure, that in paper does look good and is correct. However, we all have people that we know are going to have challenges. And so what is the right therapy? And the good thing is we now have multiple drugs available, to work with.
Frank and I both tell our patients that we want to be out of jobs, literally.
Yes. Yes.
So let me ask you another question related to this. In an era where we are exploring neoadjuvant therapy for patients who present with advanced disease, in that group who are BRAF positive, can we extrapolate from this data in terms of the value of combination versus single agent BRAF inhibitor is to say we can just go with a BRAF inhibitor if we want to see if we can improve their resectability. Is that a fair question? And can you extrapolate from this study to that in that setting?
So I think that we cannot well, you can always extrapolate anything from anything, but I think this study itself doesn't necessarily lend to that. So what I'm understanding from that question is, what about neoadjuvant therapy, right? So if the tumors are, I'm sorry, if the cancer is invading other structures, or the surgeon says we're going to get an R2 resection, which means we're going to leave gross tumor behind, then should we think about giving either single agent or dual agent to try to shrink the disease, to then do surgery? And definitely in this trial, we didn't do anything with neoadjuvant, and we couldn't show a difference between the two, so we can't extrapolate. But there is data both in the unpublished off-label setting, as well as, this is not published, but Maria Cabanillas had done a trial in neoadjuvant papillary thyroid cancer with Dabrafenib, another BRAF inhibitor. And I think it only went to ESMO, but never went to, it hasn't been published yet. But it did show, out of the 17 people that went on the BRAF inhibitor, 11 of them went to surgery, and 8 of them had an R1, an R0, R1 resection. Most of them were R0, but there were some R1. And that was single agent BRAF inhibitor. Now, the thing is with surgery, if you're going to do a combination of those drugs, they like that MEK inhibitor stopped a few days before, because there is some anti-VEGF activity, whereas the BRAF inhibitor can be continued up until the day of surgery. So I think that there is a role. I think we need to prove what that role is still in differentiated thyroid cancer versus anaplastic. I'm a big believer in the anaplastic realm, which we can talk about another day, but in the differentiated thyroid cancer, we don't tend to get as much shrinkage. So I think there is a role, and I think it should be thought about. And now there's several trials. There's another trial looking at lenvatinib in the neoadjuvant setting that Greg Randolph is doing. And so, thinking about what we can do, if we can shrink these tumors, and think about, with like other cancers, pancreatic, breast, and how we're doing neoadjuvant in those cancers, and what should we be doing in thyroid cancers instead of like just chopping tumors in half, right? And like leaving stuff behind. So
yeah, I'll comment about that too, because I have my own experience doing this, and I agree with what you quote about Maria's data. So actually, I have a lady who came in. Her husband was having a TAVR and was very ill, and so she had this thyroid cancer, and basically is going to have an oropharyngeal laryngectomy because the disease was so bulky. And so the surgeon came to me and said, "Can we do something neoadjuvantly to try to help her?" And so after my success with the guy I showed you with the BRAF-Mutated, I'm like, yes, this will work. That's great. And then Mark Zafario told me, he goes, I ain't going to do anything. So I treated the lady. And interesting enough, Mark's point is, well, you can do it, but kind of just to delay your surgery, but it's not necessarily going to, to do anything, perhaps. And I had to get her through her husband's situation. Ultimately, he ended up passing away. But interestingly enough, what Naifa alludes to is correct, and Mark's correct, is clinically, I did not see substantial response. So we use CT imaging to, to look at the response, and so we're expecting to see the shrinkage of cancer and say, yay. But when the surgeon went in, they kept doing these, frozen sections, and they're like, keep going, Frank, keep going. That this lady ended up just having a small amount of disease at her tracheoesophageal groove. So she's walking around with her voice box today. So that's pretty amazing that, even though clinically we didn't see these responses, I don't think necessarily we should undermine that as the possibility that, or what goes on in these tumors. Interestingly enough, I actually had a guy who had RAS mutation, couldn't get a TKI like lenvatinib, as Naifa was about Greg Randolph's study. So I actually gave him Herceptin, dexirotecan. And for HER1 positive disease, same thing happened where the guy's disease was intact. And this was a poorly differentiated cancer when we pulled it out, but it was easier to remove with an R1 resection that we then radiated, and then gave the guy radioactive iodine therapy for his, lung disease that was present. And this guy is doing fabulous. So there is a role there. We just need to explore it more.
Great.
oh, it's time to go. I love that, Frank. I agree.
I
Yeah.
have one last question, and again, this is the surgeon asking this question here. In the crossover group where there was proved progression on dabrafenib, why not? And you got responses with MEK. Why not stop the dabrafenib and just add the MEK inhibitor? What's the rationale there? And then we're going to have to call it.
So single agent MEK inhibitors don't work very well for response in thyroid cancer. So if you stop, and the main driver is the BRAF. So if you stop the BRAF inhibitors, they tend not to do well. The exception to that is you can use MEK inhibitors for redifferentiation to sensitize them to radioactive iodine.
Terrific.
Yeah, I would agree with that.
Awesome. I am sorry that we are up against the hour here, but thank you both. Really, really stimulating talk. And Frank, do you have one last comment? What Ernie would say?
Ernie say, keep doing good things for our patients, and we'll keep exploring. And the thing we always say, everywhere is the opportunity for clinical trials comes up. Please send patients, and that's how we're going to learn, new about new therapies and new ways to treat people. So keep us in mind and participate.
Awesome. Thanks so much. Thank you both. Have a great day, and thanks everybody.
Good to see you. Thanks. This is great. Thanks. Bye-bye.
Bye-bye now.